You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Golinvaux, welcome to the Nailed It Ortho Podcast. So happy to have you on.
I appreciate you having me. It's a real pleasure.
Yeah, and we're going to talk about some trigger finger today, something that a lot of us see. I know I definitely saw it a lot when I was in clinic, and I remember I had no idea what it was, but I was trying to describe the patient's the symptoms to one of my attending without even like looking at the patient. He's like, "Oh, it's a trigger finger," so it's always a fun topic. But before we get all the way into it, we always start off with just a couple questions, just getting to know you a little bit better, or getting to know our guests a little bit better. And so we have a lot of residents that listen to this podcast, maybe third year, fourth year residents that are trying to decide what field they want to go into. What brought you towards the field of hand? Like what's the story behind it?
Yeah, so probably goes back to high school. My dad was a dentist. My mom's a dental hygienist. So I worked in their office during the summers, and I really gravitated towards the fact that they were fixing people, and they were fixing people like that day with a procedure. And so I
Yep.
was sort of probably always destined for surgery, but I didn't love the mouth. So I went to med school and predictably fell in love with surgery. And as soon as I saw orthopedics, it was game over. I loved orthopedics. And but within orthopedics, I mean, I've heard a lot of your guests sort of say this before. It's the variety of the hand and upper extremity. So I mean, if you take a day like today, I started the day with a few carpal tunnel, cubital tunnels. And then I went and did a distal biceps repair. And then the next room over, I was doing flexor tendons and nerves under the microscope, and then finished off my day with a hand fracture. And tomorrow morning, I'm up early doing a Montasia. So the variety
Oh
is
man.
just the best. I mean, you get the whole upper extremity, all those different surgical techniques and anatomy. So that's what hooked me.
Yeah, that's a solid day. I can't lie.
Yeah,
That
it's
is
a lot of
solid.
fun. Yeah,
Nice. Well, yeah, those are some good cases. And we were
yeah.
talking a little bit off air, but now you're in private practice, and so we have a lot of people that are a lot of fellows that listen to this and early attendings that are thinking about going into private practice and are trying to figure out kind of how to. Well, first we'll start off. What brought you towards the field of private practice out of all the different type of employment models that you could go into?
Yeah, I mean, you sort of make these choices with limited information, but as my wife and I are learning with our two young toddlers, that the one of the main factors of human happiness is perceived autonomy. So
I like
I
that.
perceived that I would have autonomy in private practice, and that's usually the case, and that's sort of what drew me towards that.
Yeah, and you're just mentioning your stacked day of cases. How did you build your practice to, now you're doing, X amount, all these different variety of cases, cases today, cases tomorrow. Like what tips do you have to those that are going into private practice that you could, what tips do you have that could help them out in their journey?
Yeah, I mean, I had two really fortunate advantages. One is I'm practicing in the town I grew up in, so I came home and I had a bit of a network already here, and that has definitely helped grow my practice. Two, I joined a really established practice, so they did have some really nice referral sources already grooved for me. But there's still been a fair bit of work that I've had to put in to grow this, and you hear all these trite phrases like the three A's: be available, able, and affable, and um, some of that is really true. I mean, you answer the phone every time you answer the phone from the emergency room as a consult, that's marketing for your practice, right? And if you're kind
Yeah.
and you're helpful to that emergency room physician, those things spread. And I've seen that come back in my practice over and over again. So being available and kind is huge. And then beyond that, reaching out to primary care doctors in the area, bringing them cookies, those sorts of things. I mean, that does still work. So I wouldn't hang your hat on just one strategy, but all those things sort of have helped me grow my practice.
Yeah, yeah, all those multiple different ways. Yeah, it's kind of like being your own businessman. Like you're marketing yourself out, trying to get as many people in the door as possible. But yeah, definitely thanks for all those tips and tricks. And maybe now we can transition into the topic of the day. We're going to talk a little bit about trigger finger. And I remember trying to learn this. I remember trying to figure out all the anatomy of the hand and all the relevant structures. Could you kind of just walk us through? Just to get a baseline knowledge of the relevant structures that we need to know in order to understand trigger finger of the hand and the finger.
Yeah. So it all comes down to this flexor pulley system. And fortunately, trigger finger itself is actually very simple and occurs just around the A1 pulley most of the time. So um, uh, the way I explain it to my patients is trigger finger occurs when you get a nodule of swelling on the flexor tendon itself. And that typically occurs right around the level of the A1 pulley. And as that patient flexes their finger, that nodule actually catches and it slips underneath the A1 pulley to get it stuck there. Now, for residents, med students, anyone going into a trigger finger case, you probably should memorize the flexor pulley system. So we talk about that a little bit if you want.
Yeah, let's go for it.
Yeah, so sort of broad strokes, the flexor pulley system you can think of as one long continuous tunnel from about the level of the distal phalanx to the level of the metacarpal head. And it serves a couple purposes. One is to keep the flexor tendon nicely adhered to the bone so that you don't get bowstringing of the flexor tendons when you flex your fingers. And in doing that, it increases the moment arm and the strength of the flexor tendons as they bend the finger. And so these tendons slide in and out of this flexor sheath. And that sheath itself is made up of this series of pulleys that we've so creatively named A1, A2, and so on and so forth. But like I said, trigger finger occurs primarily at the A1 pulley. So that's sort of the high level anatomy.
Yeah, and the odd ones are the ones that are like right over the joint, right? Like the A1, 3, and
Yeah.
5. And so
Yep.
does A2 or 4 does it really matter? Like do those other ones, because we always talk about the A1 pulley for the most part when of course obviously with trigger finger, but do you need all the pulleys? Like does it does it matter?
Yeah. Great question. So, it's like that divide between what matters when you're being you have a pop quiz in the OR with an attending, and then you're doing the A1, A3, A5 over the joint thing. But in my practice, A2 and A4 are what it's all about. So if you're talking about a flexor tendon injury, we are doing everything we can to preserve as much of A2 and A4 as possible. You cut the rest of it to facilitate your repair and make for nice, easy gliding with a flexor tendon repair. But A2 and A4, if you lose those, you're in big trouble. You're going to get a lot of bowstringing.
Oh, okay. Well, that's good to know. And so how does like trigger finger happen? Like what like how does this
Yeah.
occur? We have these normal pulleys that we're born with, at least most of us born with just normal pulleys, and all of a sudden we have this trigger finger. What kind of what's the how does this happen? How does it occur?
Yeah, it's a great question. And the real answer is we don't fully know, which is crazy. This
Yeah.
is one of the most common things that we see in all of orthopedics. And, we look at it under the microscope and it shows there's some degenerative metaplasia. And, you get chondrocyte proliferation and all these things. I just describe it to my patients as inflammation, but it's probably a little bit more complex than that. Um, so, in large part, it's a degenerative process. My sense is that it sort of starts with an unrecognized injury, maybe a little stretch injury of the finger. You get a little degeneration within the tendon, some inflammatory buildup, and then all of a sudden you've got a nodule on your flexor tendon that's getting caught under the pulley system.
Yeah. Okay, perfect. And so, we have this nodule. And so, say, for example, you have a patient that comes in and they're in your clinic and they just say, my finger hurts. Like, what in your head, what set of questions do you ask them? Like, say, we're going into the history and the physical exams. What set of questions are you asking them? And what do you want to find out from the patient? And then if you could walk us through how you actually examine these patients. So, hopefully our second year resident on their hand rotation going into clinic tomorrow can catch this.
Absolutely. So the easy trigger fingers are, I mean, you can see them from the door, and the patient already knows they have one, right? Those patients come in and they say, my hand's been sort of sore for the last couple of months, and pretty soon after it got sore, it started clicking, and every time I grip something, it gets stuck, and I have to, either forcefully undo it or actually use the other hand to unlock it. And the patients can feel it, and so it's not a subtle diagnosis in that case. But there are plenty of things that can throw you off. So I don't know if we'll talk about the classification later, but
Yeah.
the first level of Green's classification, grade 1, is this pre-triggering. And those patients will just come in and they'll sort of complain of hand pain. It's just like palm pain. And it can be really difficult to pin down if they're not at the triggering or locking phase. So always keep that in the back of your mind when someone comes in with pain through this area in the palm. It's
Yeah.
probably an early trigger finger, with common things being common. Um, uh, Oftentimes in the history, the patients will note that it's worse first thing in the morning. We think that's because people sleep with their fingers flexed, and that nodule is able to stay out of the sheath all night and sort of accumulate additional swelling overnight, and then it's harder to glide in the morning. So that's sort of another clue in terms of the history. Physical exam is also fairly straightforward. So they're always, always, always tender over the A1 pulley. And you can, if you put your finger there and you have them flex and extend, you can feel that nodule sliding in and out of the A1 pulley. And so it's an immediate feedback type of exam. You can feel it right away. Although I will say there's sort of two major pitfalls to this exam. So one is in rare cases, you can have a sagittal band injury of the extensor apparatus. And in that case, the extensor tendons, as you flex, will actually fall into the groove between the two MCP joints. And that can cause the finger to trigger. And don't ask me how I know this. Fortunately, I haven't been in this situation, but I will never forget an experience in training where we released a trigger finger. It didn't get better. We flipped the
Oh.
hand and asked the patient to move their finger, and sure enough, it was the extensor apparatus. And
Oh man.
yeah. So do that in clinic. Always flip the hand and make sure that their extensor tendons aren't the cause. And then the other thing that you'll see is people will start to develop a PIP contracture. So if this has gone on too long or it's particularly painful, the brain will stop moving that finger through its full range of motion. And then week by week that goes by, that PIP joint starts to develop a flexion contracture. And this is really important to document and point out to a patient preoperatively, because they will be upset with you postoperatively if you didn't fix their flexion contracture.
Yeah.
And that's not a part of trigger finger surgery, right? We release the A1 pulley and then they have to work out that contracture on their own. But it's probably one of the biggest changes I've made in my practice is being very clear with those patients who do come in with a contracture, pointing it out to them and then helping them with strategies to get rid of that once the triggering is gone.
Okay. And so what is the, if you had to go like with the epidemiology, like what patient population are you seeing that comes in with this? Is it like kind of more predictable, like, oh, this patient, like this is kind of the profile of the typical patients that come in, or, kind of what's the
Yeah.
epidemiology of patients that have this type of injury or this pathology?
Well, it's fascinating because you can get the kids or the 2-year-old with a pediatric trigger thumb, which is actually a completely different entity, but gets lumped in with this, all the way to the 90-year-old, and everything in between. But if you're going to pin your hat on a classic patient, it's the healthy 50 to 60-year-old female patient. It is more common
Yeah.
in women than men. I've always read 5-1 or 6-1. I don't know that I really see that in my practice. I'd say like 2 or 3-1, but who knows?
Really? Okay.
And then you get, common things being common. It's usually just a plain old trigger finger, but you also do see it more commonly in folks who have diabetes, or some of these inflammatory conditions. They will definitely form trigger fingers more than the average person.
Yeah, and you piqued my interest earlier when you talked about kids and you're saying it's a complete different entity. Is it not well, I guess what do you mean by that? Can you expand on that?
Yeah. So in adults, it is sort of a degenerative by nature nodule, and we always talk about it being a nodule that forms on the tendon, but oftentimes it's actually just thickening of the A1 pulley. right? So
Yeah.
it's not always a nodule itself on the tendon. It can just be a thickening of the pulley, and this is degenerative by nature, and you get all the chondrocyte proliferation and stuff that we talked about before. Obviously, 2-year-olds aren't having degenerative disease. Now
Right.
they do find like these mature um, uh, collagen fibers within the nodule on the tendon, but it's truly a nodule within the FPL that's not degenerative in nature that's causing the pediatric trigger thumb.
Ah, okay.
And then
Okay.
if you want to keep going, the pediatric trigger finger is a whole separate thing, even from the pediatric trigger thumbs. And those are oftentimes abnormalities in the FDP FDS crossover, some thickening of the FDS. So pediatric trigger fingers typically do not respond just to an isolated A1 pulley release.
Okay. Cool. Yeah, that's good to know. And so, you mentioned, this could happen in kids or adults. You mentioned on the history they may just have palmar pain, and on exam they may have tenderness right at the A1 pulley and a little nodule. And you also mentioned the green grading system. What is, I guess, kind of, do we need to know? We talked about the grade ones. Can we quickly go over some of the other grades, or kind of at least maybe just mention what we need to know about it?
Yeah, yeah. I'll be totally honest. No attending I ever worked with ever used this.
Oh, perfect. Good.
Uh,
So maybe we don't need to
but
know
it is, yeah. I
it.
don't. I mean, I don't remember it being on any test. But as with a lot of
Good.
these classifications, it's helpful to at least know that it exists. So these do not correlate to outcomes. They can be helpful for documentation and research purposes, right? So grade 1, you basically just have pain. It's pre-triggering. You're not actually having anything that you can feel on exam or that the patient experiences other than pain. Grade 2 is sort of the classic trigger finger where they feel it popping in and out every time that they use the finger. Grade 3 is where it actually is physically getting stuck, and they either have to passively unlock it with their other hand or exert a tremendous amount of strength to open up the finger. And then grade 4, I was previously taught that it's triggering with that PIP contracture that I talked about.
Ah, okay.
But I think that was the old, I think it was the Quinnell, and then Green modified it to actually being a fixed locked finger, which I only see about one a year. But sometimes people come in and they cannot unlock their finger no matter what they do.
Ah,
So it's a
okay.
pretty severe one.
And so how do you treat them? Or well, actually, let me take a step back. Do you get any imaging? Do you need imaging to make this diagnosis, or is this just mostly a clinical diagnosis?
For me, this is totally clinical. I don't get any imaging for this.
Yeah. And then so how do you go about treating it, right? Do you can you talk about the non-operative treatment, and then when you do it, and then we can go on to kind of the operative treatment.
Yeah. Typically, I first assess whether the patient is having triggering at all times or if it's worse first thing in the morning. Those patients where it's worse first thing in the morning, some of them ultimately will do well with nighttime splinting. It's not something I routinely push on people or convince them it's the end all be all, but some people are a little bit leery about injections or surgery right off the bat, and they want to try something else first. And especially for those where it's worse first thing in the morning, just sleep in a night splint for 6 weeks and see if it goes away. I tell patients not to wear it during the day, not to wear it for more than 6 weeks, or they'll start to get stiff. But just putting a simple Alumafoam on at night before you go to bed oftentimes resolves these. But the mainstay of treatment in trigger finger is either corticosteroid injections, or surgery. And it's interesting. You have to be really clear with patients what you're talking about in terms of the success of a treatment. So how do you define success? Is success a total cure and this never comes back ever again? Or is it, relief from the pain I'm feeling right now, and we'll see whatever happens later. And so when I talk to my patients about trigger finger injections, over 90% of people who get injections will be cured a month after the injection. Now, whether that cure lasts permanently and is truly is a cure in the formal sense of the word, that's about a 50% rate. So one shot totally treats and cures the trigger finger injection in half of people. And then in half of people, it goes away for a period of time and then maybe comes back 3 or 6 months later.
And
So
are
I
you
start with,
injecting
yeah,
sorry, because you are you injecting the tendon? Are you injecting just a pulley, or are you just putting it in the general area? Where are you injecting?
yeah,
Are you just doing like Canalog or just any kind of steroid with lidocaine?
yeah. I use a betamethasone with lidocaine, and I
Okay.
just use a half cc of each. And there's been some pretty cool studies over the years looking at ultrasound guided injections that get perfectly into the sheath, but just above the tendon, but just below the sheath, and flooding it perfectly and all that sort of stuff. And ultimately, it almost doesn't matter, believe it
Okay.
or not.
Good.
So
Good to
if
know.
you get steroid in and around the A1 pulley, they are going to have good relief from a trigger finger, more likely than not. And so I don't use ultrasound guidance for this. I do for other injections, but not for this. And I really I pop through the skin. I have my needle go down until I feel the resistance of the sheath. Um, and then I try to pop through just a little bit further, but I never ever inject through any sort of resistance because I don't want to be doing an intratendinous injection of steroid. In theory, that would increase the chance of rupture. And so
Yep.
I get down to that level, and if I don't feel resistance, I put the steroid in, and it takes about 10 seconds.
Cool. And then I think you're going to talk about operative treatment.
Yeah, one more thing on the injection. So it's sort of
Yeah. Yeah.
interesting. That first shot, like I said, most people get at least temporary relief. The success rate for long-term cure is 50-50. Of those patients who fail and come back for a second shot, the success rate is the same. It's still 50-50. So most patients will sort of be willing to have 2 injections before considering surgery. And I think that's been proven to be the most cost-effective treatment of trigger fingers. So 2 injections before surgery.
Oh,
Some patients want you to inject them 6 times, which I won't do. But even the third injection, if they've failed 2, still has about a 40% chance of curing a trigger finger. So that's sort of an all-comers. That's not quite as true in folks with diabetes. But it's sort of a nice framework to think about, and it's easy for patients to grasp.
yeah. Yeah. So really, if you break the 50-50 down and another 50-50, I guess that makes it what, 75% likely
Yeah,
with two
yeah, I'm no
shots.
math whiz, but yeah, it's not exactly. That's why I tell people, I'm like, about
Right?
75% of people will be cured with 1 or 2 shots. And you think
Yeah.
about all the injections we do in orthopedics. A 50-50 cure rate with 1 shot, that's about the most
It's
effective
not
thing we
bad.
do. I mean, we're not curing
Yeah.
arthritis with steroid injections, right? We're just taking away the pain for a bit. So as an actual treatment, it's a pretty cool, pretty simple option.
Yeah. And so when do you go to operative treatment? What are your indications? And then what are you doing?
Yeah. So in the all comers, I will pretty much never start with surgery. Uh, After they've failed 1 shot, I really leave it up to the patient. I will walk them through the pros and cons, and some patients are tired of dealing with this and don't want to fail another shot, and are tired of waiting around, and they just want to go have surgery. And I think that's reasonable after 1 shot. I would say the vast majority of my patients that I operate on have failed 2 injections. So that's my standard, would be 2 injections first and then surgery. Um, Couple caveats there. If someone comes in truly with a locked digit, that's not going to get better with an injection. If they are having locking where they have to manually unlock their finger, I warn them that the chances of an injection curing it are lower, not zero, but lower than the
Yeah.
average. And then the patients with diabetes are sort of another realm to consider. So injections are less effective in folks with diabetes. Um, and if they're using insulin to replace their or to treat their blood sugar, steroid will elevate their blood sugar for a day or two. And so if that makes them nervous, if they've had bad experiences in the past with trying to keep up with blood sugar spikes, some of those patients just opt for surgery right away.
Okay. Cool. That's great to know. Good information. And definitely helpful for counseling patients on what to expect with, with steroid injections, watching their sugars, the efficacy of treatment. And then so can you go over operative wise how you do these cases, and to say we have the patient that you've done 3 injections, they tried it, still having locking. It says, "Doc, I just want to get rid of it. Please help." What do you do?
Yeah. So the first thing to consider in that case is how long has it been since your most recent injection? We have pretty good data that within 8 weeks of your most recent injection, your infection risk is higher at the time of surgery. So um, there's even some data going out to 3 months. So if I can, I try to hold my patients off at least 3 months after their most recent injection. Um, I think that's a little conservative. I think 6 or 8 weeks is probably fine, but I don't want to mess with an infected trigger finger. So
Yep.
usually the patients are on the same page there. And then most of these are done under local. Every so often, if someone's really uncomfortable with that, we'll take it to the operating room. But um, after a standard field block with local anesthetic at the A1 pulley, just like those incisions you have there in your video, I make about a 1 centimeter oblique incision over the level of the metacarpal head, which is right where the A1 pulley is. And then a couple scissor spreads down to the level of the tendon. Uh, Always helpful to have a assistant retract gently on either side of the A1 pulley, because that's where your neurovascular bundle will run on either side. And then it's about as simple as it gets. You just cut the A1 pulley longitudinally, and you see the edges relax, and the tendon gives a sigh of relief, and you have the A1 pulley opened. At that point, I will pull each tendon out of the wound, sort of like you have in the picture there, and evaluate the quality of the tendon and any associated tenosynovitis or just sort of, oftentimes you see a lot of junky tissue on the tendon. And I will clean that off within the extent of the wound, but I'm not going to extend the wound and go chasing every last little bit. The nice thing about doing these under local is that then you ask the patient to make a fist, and hopefully their triggering is gone, or else you got
Yeah.
more work to do.
Yeah, no, that's great. Yeah, the ones that I've seen is just being all exactly how you just described it. Incision, go down, you cut
Yeah.
the pulley.
Yeah. I mean, sometimes it's nice to do something simple.
Right? Yeah, I agree. And so just reading on this, there were some another treatment option besides just the A1 pulley release, what's called an FDS slip excision. Now my sports brain is trying to understand what this is. Can you take us through, or more kind of when this is indicated, and what it is and what exactly you're doing?
Yeah. Yeah. So this is like this is the when you're having a bad day in the OR sort of thing. This is always what you'll see as the next option to do for a trigger finger if the A1 pulley isn't releasing. So um, maybe I'll just sort of go based off your slide there. So the first bullet point you have there is in pediatric patients. So this is what I was mentioning earlier. A pediatric trigger finger, not a trigger thumb, but a trigger finger, is usually not a nodule at the A1 pulley. Typically, we do still release the A1 pulley in a pediatric trigger finger, but you need to plan to be resecting a slip of the FDS at the same time, because most trigger fingers in kids are actually abnormalities of the FDS. You can get thickening of the FDS. You get abnormal crossover with the FDP. You can get triggering underneath the A3 pulley. So 9 times out of 10, or maybe even more, pediatric trigger finger does need an FDS excision. Maybe I'll go through the other indications, and we can talk about that technique.
Yeah, sure.
Circle back, because it's the same in everyone. So if an adult patient, you release the A1 pulley and they continue to trigger, you either flip the hand and look for that
I was
extensor
gonna
tendon
say
nightmare that I talked about,
that. Yeah.
or you presume that they have sort of a rare um, uh, abnormal crossover or triggering under A3. And so that's another time where you would do an FDS excision. And then the last bullet point you have there is in rheumatoid arthritis. So this is a little bit historic, with all the DMARDs and everything. We don't see that so much anymore, but in days gone by with really bad rheumatoid, you get horrible ulnar drift. There was this theory that if you release the A1 pulley, you would further destabilize the metacarpal phalangeal joint, and cause more ulnar drift. And so there was sort of a practice of doing an FDS slip excision in some of those patients to prevent that. In reality, it's not really something I consider in my practice. I do A1 pulley releases on rheumatoid patients that are well controlled and haven't had any issues.
Yeah.
So really, this is just sort of a deep bulking surgery. The FDS tendon, if you remember from your anatomy, it goes down, and within right about the level of the A2 pulley, it splits into two slips. And at that point, it wraps around the FDP tendon to go down and insert ultimately on the middle phalanx, while the FDP keeps going on up ahead, up on top of it. And so you don't really need both slips. You can generate really nice power in terms of PIP flexion with one of those slips. And so if there's a bunch of junk in the way, cut something out is sort of the theory there. And so we resect a slip of FDS. Every textbook ever will say you take the ulnar slip. I think that dates back to the same rheumatoid argument that if you take the radial slip, then maybe you'd destabilize and you'd have more ulnar drift, but it's a little bit arbitrary at this point.
Yeah. Oh, that's good to know, especially to know about the FDS slip excisions and when those are going to be indicated, like you mentioned, like the pediatric patients, the chronic patients, and then the historic kind of, rheumatoid patient, but now they have the DMARD, so not necessarily seeing that as often. I thought this was a great podcast. Anything else that you want the people to know about trigger finger that I may have missed, or anything else that you think is important for people to know?
I don't think so. I mean, it's one of those things that's super common. Almost always it's the easiest clinic visit I have. It's just in and out and pretty obvious. With those, just keep those couple pitfalls in the back of your head, either with the PIP contracture that goes unrecognized and the patient's unhappy later with unrealistic expectations, or the extensor mechanism issues that can cause triggering.
Well, Dr. Golinvaux, this has been an excellent podcast. Thanks so much for coming on. I know I learned a lot about trigger fingers. So, starting off private practice, I'm seeing everything. So if one comes into place, I'm going to think back to what you said and flip the hand over to make sure it's not the extensor tendons.
You can tell I've been scarred.
Yeah, again, thanks so much for being a guest on the podcast. Happy to have you on. Those who are listening, we hope that you enjoyed it. And we will see everybody next time.